Your host, Glenn Mays. Happy to be with you all here today. And coming to you from the National Coordinating Center, and we also have with us online Anna Hoover, who's our new Deputy Director. I think everybody met Anna last month at our PBRN grantee meeting, as well as Lizette Fowler, who is also a relatively new member of our staff on the PBRN program as well. And then I also have with me Rachel Hogg, who is one of our graduate research assistants with the program. And I see that we've got a pretty good cadre of public health folks already on the line, and probably have a few more people joining us here shortly. We have an interesting session for you this month. As usual, we'll spend the first half an hour or so, 30, 45 minutes or so, hearing from our Connecticut Public Health PBRN about some research in progress underway up there. Connecticut has a series of interesting studies that are underway within the public health system up in Connecticut, and today we're going to hear about one of those projects, looking at public health financing issues in the revenue stream, service delivery in Connecticut local health departments. Debbie Humphreys, we're pleased to have her join us today. She's a colleague in the Connecticut Public Health PBRN, and she's a faculty member at Yale University School of Public Health. She has a broad background in public health practice, has done work in the very important issues of diet and physical activity, behavior change, done a lot of work in looking at sustainability of public health programs, both domestically and as well as a lot of international work in this regard, and lots of work in program evaluation in public health, as well as in training in program and in program implementation and program monitoring and evaluation. So we are very fortunate to have Dr. Humphreys with us today to talk about some research in progress in the Connecticut PBRN. So if you're ready, Dr. Humphreys, we will turn the virtual podium over to you.
Great. Thank you very much. So I'm happy to have the opportunity to share some of the work that we've been doing. We first were able to provide initial reports on this work in February, which is why the date has not been changed to reflect that this is now May. But what we've been looking at are really how the revenue streams, how the structures of where the funding comes from, how that affects service delivery. Funded by the PBRN, a big piece of the question was really around the recession, 2007, 2009, wondering how that might have changed the ability of local health jurisdictions in Connecticut, both their revenue and then the services they were able to use or able to provide their constituents. One of the interesting background pieces is that Connecticut has a mixed health jurisdiction structure. We use the term local health jurisdictions because it's both departments and districts. In 2001, which is when we started our study, there were 106 jurisdictions. That changed until through 2010 down to 75. We have both full-time single-town health departments where the health director is full-time, part-time single health departments where the health director is part-time, but they certainly provide, there may be other full-time people on staff, such as a sanitarian. And then districts where multiple towns and cities have come together to provide their, to have their health department services, their public health services provided through that district. We had 4 main questions. Really, how has the profile changed over time of both the revenues and the services? Were any changes in the economic conditions? We were trying to get at this recession issue measured by unemployment and housing permits. Were those then affecting the revenue and service provision? Did any other factors besides those local economic conditions explain some of the variation in the fees, the money coming in? You know, were they able to generate more revenues by raising fees, or, for example? And did it change the services they provided? Did they, for example, switch more to services that they could charge a fee for and perhaps cut services that they could not charge a fee for? And then following up on that, what coping mechanisms did the jurisdictions use to respond to the economic downturn and the anticipated reduced revenues? We decided to pursue 2 different phases. First, to do a quantitative analysis, and then to follow that up with a qualitative analysis and a series of interviews to follow up on what we found in the quantitative phase. We used already existing annual report data. Every year, each local health jurisdiction is required to submit their annual report data to the State Department of Public Health, and then we supplemented, and we took that annual report data, then we supplemented that data with other Connecticut data, drawing housing, unemployment, population, whether a jurisdiction was a rural or an urban jurisdiction. As part of that quantitative analysis, we were really looking at trends over time in fees and services, and then we also used regression models to look at which factors were most important in explaining the variation that we did see in those fees and services. The second phase was interviews with directors of health. We wanted to get a variety, as some of the quantitative analysis identified that urban and rural issues, and then district versus the full-time and part-time, and so we were developing a proposer sample to really try and get a saturation of issues. We recorded the interviews, transcribed them, and then had the transcripts coded by at least 2 independent reviewers, and then looked at key themes around coping mechanisms and then other influences on the revenue streams and services. When we started, we developed a framework to try and lay out how we thought the relationships and movement of the revenue-generating services would then affect revenue and personnel, the external influences. We changed this framework through the course of the project, and later on I'll actually show you the framework that we ended up with, feeling was a more accurate representation of the way revenues and services interact in the local health jurisdictions. So we had this annual report data, and the first thing that we did was say, okay, what do we really want to, what would be the best indicators of service that we could have? So ideally, we wanted indicators that would map to the CDC 10 essential public health services, that were available across all 10 years, that were able to measure the quantity of service provision, as well as some measures of quality, and ideally that showed variation across the years and across the jurisdictions. What we were able to do, we were not able to go to the CDC 10. Instead, we mapped it to the Connecticut 8 essential public health services. These are what are legislated in Connecticut. They were available across all 10 years. We chose a mix of indicators that looked at both quantity and yes, no. So we have about half that were continuous and then another half that were just indicators. We were not able to measure anything that looked at quality of service, and then we did have a good variation across the jurisdictions and years. What we ended up using, so that on the left-hand side, you'll see the Connecticut 8 essential public health services, public health statistics, health education, nutrition services, maternal child health, communicable and chronic disease control, environmental services, community nursing services, emergency medical services, and then just a cross-cutting indicator that we chose. And then on the right-hand side, you'll see the indicators that we chose to represent that service. So I want to start in terms of showing you our results, I've got some slides that just show some of the variation and change that we see across the 10 years. So this is, it's just stacked bars showing the average revenues per capita, so that these are brought down to, so that it's $14 to $18 per capita, and so these are per it's per thousand population. We're showing the blue, which is our local revenue. You'll notice that that accounts for the bulk of the funding, and that's whatever comes from the local municipalities or the member municipalities when it's a district. The pink, the next bar, is the state funding. Green is the federal. Blue is other sources. That might be other grants. Yellow are the license fees, environmental health kinds of licensing, restaurant licensing, inspections. Peach is program fees, and then immunization clinic fees. So really the bulk of the funding that's available in Connecticut is from the local revenues, but that does change when we look at urban versus rural local health jurisdictions. On the left, you've got the urban, where there's an average of $15 to $20 per capita, and then in the rural, where the local is lower and there's almost no state or federal funding available, and those go down to an annual average revenue of $3 to $9 per capita. Taking that rural-urban down a little bit, the full-time LHJs are really the driving force in that upper end. They're getting $20 to $34 per capita, and more both from the local revenues and also the state and federal. These are the districts. Interestingly, the districts and the part-time local jurisdictions are getting almost half of what the full-time LHJs are getting. And the districts are getting the state and federal funding, but about the same of the local revenues that the part-time LHJs are able to get. And then the part-time LHJs have a little bit less on the licensing and definitely the absence of state and federal funding for those part-time jurisdictions. When we look at it as the percentages, just to take out the absolute variation, there's still interesting differences between the full-time and then the districts and the part-times. So if you, both the full-time and then the districts have multiple sources, but the part-times are really, really dependent on those local revenues. So in this initial phase of our work, we also looked at how a number of the different services and the indicators that we were using varied over time. And we found it was interesting that some of the services were actually very stable, and the food service inspections seemed to be one of the most stable across all of the LHJs. Variation in well permits, septic, sewage lots, as expected, there's some variation with rural, urban, but I'm not going to go into that. This is the average across LHJs. Clear drop in permits during both going down over starting as early as 2002, 2003, coming down to that bottom in 2009, and then some initial going back up. We haven't looked to see what happened since then. So nurse on staff, health educator on staff, dietitian or nutritionist on staff. These are yes-no questions, and all are relatively low. Dietitian or nutritionist is definitely almost nothing in those later years. So the results that we, after taking both that descriptive piece that I've walked you through and then going on into the multivariate analysis, were changes in economic conditions as measured by unemployment associated with change. So housing permits was not associated with changes in fee revenue or service provision. Unemployment rate was associated with some reduction in staffing, but not with changes in fee revenue or other services. So then the third question of, were there other factors? Yes, rural, urban, and then the type of local health jurisdiction did matter for some of the service outcomes. So the next thing that we did was really to say, why? Why did we not see the changes that we had expected in revenue or services in this data? Let's go ask the directors of health what they were doing to respond to those downturns that were not captured in that annual report data. So we interviewed representatives of 20 different local health jurisdictions. We interviewed 17 individuals, but some of them were actually, some of the part-time directors represent multiple jurisdictions, and we are trying to catch a variety, a diversity of views by looking at a range of participants. When we read the transcripts, we actually did it in two different processes. The first one is that we looked really quickly to identify coping mechanisms, and then we were able to get a group of the public health students at Yale who are putting together a consulting service to go through, and they then went back and coded all of the transcripts very thoroughly for us. And so they took the lead on really identifying the key influences on revenue streams and services. So the coping mechanisms that we were not capturing in the annual report data, they had ways of coping that addressed their revenue issues, services, staffing, politics, partnerships, and then the key influences on revenue streams and services. I'll start with the coping mechanisms. Really just the same, these 5 domains that we were looking at. So some of the coping mechanisms addressing revenue, we can't control the per capita. and we can charge fees for services. So we started charging fees for services. These are the districts where each district sets a per capita fee that is then assessed to each member municipality. And because they set that one per capita fee and all of the municipalities have to agree to it, they have some challenges in changing that per capita. The districts, however, can charge fees for services. And so that's one of the ways they cope, is by generating more revenues. So in terms of services, they talked about cutting extra things. We're not doing those extra things, but I do believe we're fulfilling our role in the minimum of what public health needs to do in a town. So they were pretty clear that they were doing their best to really cover what's needed, the minimum public health needs, but that they didn't have any extra services anymore. Also, some of the districts did speak to cutting services if it was needed. If they had financial resources cut, if they lost a grant, they cut services. There was a lot of effort to protect staffing. And so some of the jurisdictions did speak about having to do layoffs and reductions in programs, but those weren't necessarily captured in either in the indicators that we were using from the annual report data. One of the ways they adapted, one of the districts reported that they do a lot of minor scheduling, so that people work 33 hours instead of 35. They get furlough days. They spoke about the director and the assistant director, deputy director, maybe working one day for free. Different ways that they made small adjustments to try not to lay anybody off, to really protect the staffing. A key piece that they cited, both in terms of the coping mechanisms and in the things that affect what they're able to do, is really politics and their relationships with the local officials. Men's rooms and ladies' rooms and the position of your office matters. And the ease of access to officials was really important, and the part-time in particular, but also the full-time, and the district spoke about that. Another thing that they used to cope with reductions in funding are really looking at ways to partner with other health departments, with neighboring health departments, so that they would collaborate, for example, on equipment and share it so that they had more available than they could provide by themselves. So switching to those, the influences on revenue streams and services, not so much on how they cope with it, but what is actually affecting it. Really, they spoke strongly about service providers, service priorities, again, that political climate and political relationships, some of the structures, and then just specifically how those funding streams affect budgets and services. In terms of service priorities, I'm actually condensing a lot in this part of the, in this set of findings. Service priorities are determined by regulations, community needs, local political priorities, the priorities of funders, and then the health department staff. What they think is important does matter. Just a couple of quotes in this area in terms of service priorities. They are, what we offer are mandated by the statute. The health departments are charged with enforcing the public health code, and that's complemented by the city ordinances. So most of the services, we don't need to sit down and think about what should we do because they're established and we do those. Now, a slightly different perspective, the public health person in me says the services that are most important are the services that are going to have the most impact on preventing diseases and promoting good health. But the reality of life is getting actual funding for that is very difficult. So while the public health professionals may have priorities, sometimes that's not what's driving what's happening in these health jurisdictions, in the local health jurisdictions. And then here we come back to that political issue. From a local health department perspective, the most important change comes when the mayor or first selectman says, I know it's a fine health department, but actually we don't need all the services you're doing. We just need basic environmental services. All the rest of those things that you do, they're wonderful, but that's for another time when we can afford them. So all these things about communicable diseases and obesity and nutrition and physical activity and blah, 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 they're luxuries right now. That's the nexus of the economic and the political scene, which has brought about the most fundamental changes in this particular health district. So that the challenge of balancing both the public health priorities, the regulation priorities, and then the political feasibility, all of those things go into what a particular jurisdiction will choose to make a priority. The political climate, really, these directors are active. They work really hard to maintain relationships with the mayors and the town officials, and they're clear that they need to be advocating for their budgets and for the issues that they want to see supported. For example, I've always felt like I could be up front with all of our municipal officials. They're very clear that part of that relationship is about educating the officials about what public health is, and then being clear so that the officials don't get surprised. This particular director says, I've always told when we were actually looking at adding towns, I've always told the officials in the new town to talk to the officials in the towns we currently serve so that they'll have some perspective. And I think it shows that I trust the dialogue that will happen with those officials is going to be a positive one. And I also think it gives them some comfort to know that we have the credibility that they can actually go to someone we've served for 25 years and they'll get a positive response. So this is coming from a district where they may be looking to add additional member municipalities, and that their strong relationship with the current members then speaks to their ability and their reputation for adding new members. Another perspective, I'll tell you that the selectmen who ultimately approve my fees, again, they're asking for each fee to justify that particular fee. They're representing the town, they're representing the residents of the town, and they want to be sure the town residents are being treated fairly and not being gouged. So this is particularly when it comes to some of those inspection fees and licensing fees. And the directors have to be very careful. Some of the districts now are more independent and can generate some revenues through those services. The part-time and the full-time jurisdictions have less of an ability to do so. So they're clear that they have to justify everything, the fees in particular, to the officials. Switching to looking at how some of the structures and systems affect the revenue and service relationships. The rural and part-time local health jurisdictions rely primarily on local funding. So they're very close to their funders, and that's those town officials, and they work hard to maintain those relationships. Districts actually report competition for municipalities, which is not always positive because the municipalities would have a tendency to say, well, we can get this per capita charge from District A, and you're wanting to put it a little bit higher. And so there ends up being a very interesting competition to have a low per capita fee to add to make it a particular district competitive for member municipalities. The jurisdictions do report collaboration with each other in other ways. And then it's clear that population demographics have changed significantly over the last 10 years, 20 years, and that's changing what's happening and the services needed and the revenues that are coming in. So the biggest influencing factor on revenue are our neighbors, because if we go up, and this is with the per capita, to meet our needs and they're not happy, they'll look to neighboring health districts. And if it looks better on the other side because it's less expensive, doesn't mean the services are better or comparable, probably, then it becomes a threat. And we haven't had a lot of that, but that's because everybody, all of the health districts try to stay in their own lane. But for example, a neighboring health district staying so low and being on my border, it keeps my per capita low because he just gets bigger and bigger. And so this is back in those, the graphs about the revenues and the budgets of the districts were closer to the budgets per capita of the rural and the part-time jurisdictions than the full-time, in part, we think, because of this competition issue. Now, this is a part-time director who says that I think my towns have been slightly buffered because of the casinos. One town is in between both casinos, so that area has been buffered from some of the economic downturn. A lot of projects that probably could have gone forward, however, because of the funding crisis, a few other things have been shelved. So things are getting put on hold that weren't that hadn't been implemented, but were hoped for, and were no longer able to go forward. In terms of how those funding streams affect the budgets, the primary sources of funds are state and local governments, particularly for the full-time in the districts. They do get that state money coming in. Districts really struggle to set that per capita level with member towns. License and service fees vary, and the larger jurisdictions had more grant funding. This is coming from a full-time jurisdiction that on the one hand, the city budget has been impacted. Over the last year, we had a serious deficit, which led to a number of layoffs and reductions in programs, and staff obviously felt they weren't being supported in the program. So it's been a hard time to run a department with a short staff and with few resources. However, the health department also has special funds, which are state or federal funds, so some of our projects aren't being impacted directly by the city's deficit. They do have a little bit of a buffer, and even still the state was in a big deficit, and the federal government's also trying to reduce the budget, so there's an impact from all of the different government funding sources that full-time jurisdictions have access to that are cutting them and squeezing them. In some of the districts and then the part-time, which tend to be a little bit more rural, the housing market bust had a particularly significant impact. Specifically, less houses were being built, so we are getting less revenue from permits and service fees, such as well permits and septic permits, soil testing, evaluations for septic. We've had a reduction in the number of food service establishments that we're permitting. Some of the mom and pops are going out of business. So these sources of potential revenue are also affected by some of these economics, which we did not see in that larger analysis. The ways in which funding streams also then in turn affect services, sometimes they have direct effect, particularly when there's cuts. Interestingly, the rural part-time local health jurisdictions reported the least effective budget cuts. And another struggle that was reported was just that grant funds, when they're available, are not always provided in a timely way, and so some of the departments have more difficulty accessing those funds and being able to provide services funded by the grants in a timely way. So a little bit of background on that grant question. Almost all of the time, whatever we're going to do, the activity comes before the money. What happens is we sign a contract and we hire a person from the outside to come in. They're an independent contractor, and we try to start that as closely to the start of the contract period as we can. Especially, I think, like city health departments, they can't do what we do. We've never ever lost money. The state grants always come through with what they say they will. It's maybe gotten a little better, but not much better. There's a big lag between implementation and payment that's coming in for that contract. And so districts have the flexibility to start, but the health departments may not have the flexibility to start until the funds are there. In terms of other ways that those funding cuts do come back to the services, a service would end if you have to cut staff or if a grant was cut. That would be the only answer. So that they do try to hold some extra money, but sometimes that's not around. So when the grant is cut, you do cut the staff that are associated with it. Probably the political answer and the right answer would be to find another source like other grants, but as a city, we're not a 501c3, so I can't even really compete for the types of grants that may be out there because I'm a city. It's the perspective of one of the full-time health directors. So the last piece that I want to share is really coming back to how we reshaped our understanding of the influences on revenues and services for the jurisdictions in Connecticut. The first framework that I showed you was actually combined for the full-time and part-time and the districts. The last, where we ended up, is actually having two different frameworks, one for the one that you see right now, which is for the full-time and the part-time jurisdictions. And I'm going to highlight some of the key differences. So what you've got is you've got the revenue-generating services that actually most of the time go into the town or city budget. And then they come back into the revenue, as does the state budget and the federal budget. The health director's influence is critical on this line from the town or city budget into that revenue. You've also got the rural-urban factors in terms of the external influences, the rural-urban regulatory requirements, societal priorities, economic conditions. With the districts, it's a little bit different. The revenue-generating services come directly to revenue. And in addition, the health director's influence on those town budgets is actually much more diffuse because they have to have that relationship and that influence on multiple budgets depending on the number of member towns that they have. And those budgets, those relationships may be more challenging because they have to have them across a larger number of municipalities. And those then feed into the revenue. This additional competition from other districts is another external influence that the full-time and part-time health departments don't see that the districts do. So our conclusions are really that the jurisdictions adjust to economic downturns and reduce revenues in a variety of ways, but these adjustments aren't captured in the annual report data. The rural-urban location, district full-time or part-time are more important predictors of revenue and services than either the unemployment rate or the housing permits, which were the indicators that we chose to look at that broader economic conditions in the communities. Political support from local government officials is a really important determinant of the revenues. And then some services are more resistant to changing economic and revenue conditions than others. And we have open it up for questions.
Fantastic. Well, thank you so much, Debbie. This is really, really interesting and impressive work from the Connecticut PBRN. Let me ask folks on the call. We've got nearly 45 people on the call today. So, just in the interest of managing questions, if you would post your question, or just let us know. Type in, if you're on the website, type in your question, or just type in a note that you have a question in the chat box there, and then we can call on you that way to kind of to triage the questions a little bit today. If you're just on the phone, we'll let you chime in here in just a minute. So while folks are thinking about questions to ask of Debbie and her colleagues in the Connecticut PBRN, we do have one question from Dr. Paul Irwin from the Tennessee affiliate PBRN. And so, actually, let me go ahead and invite Paul to articulate his question, if you can, Paul.
Sure. Thanks, Glenn. Debbie, very nicely done. Just a question regarding the quote that services that are statute-based, that I think the quote was, we really don't need to think about them, you just sort of do them. Was there any interview data that came out on how well or not the statutes actually reflect current population health needs? In other words, if we just continue going along with doing what the statutes call, but the conditions on the ground have changed, are we truly making an important impact in the population's health?
I'm not quite sure. I want to tease apart your question, Paul, because we didn't directly say what do you think is most needed today. There are some quotations that suggest that they're clear that it's not all that's needed, that those Connecticut 8 are a little bit outdated, but they're clear that that's their regulatory requirement, and so that's the minimum. That's what they are accountable to their constituents for, are what their, is that regulatory requirement. And one of the service priority quotes talked about, the questions of obesity, and I don't think they mentioned Lyme disease, but, they're clear that there are other priorities, but that's not what they're accountable to right now.
Okay.
I'm not sure if that's a satisfactory answer.
Yeah, no, thank you very much.
Can I, this is Elaine. Debbie,
yeah, jump right in, Elaine.
I add something to that?
Absolutely.
I hope that I caught all of your response, Debbie, and I really always appreciate seeing this presentation, even though I've seen it several times over, but I think there's just so much richness in the interviews and all. But I did want to say that I think, Paul, were you asking, was your question also about, were we looking at whether the statutory, like environmental mandates were evaluated in any way by the health directors?
Well, maybe, Elaine, not directly. I'm just curious if anything came out in the interviews that, this is the minimum that we're held accountable for, but by the way, these things ought to change because they really don't reflect the needs on the ground.
Yeah.
There weren't any explicit that should change, but there was a fair amount of conversation, data that I didn't report here, which is about the annual report data. Yeah. And there were a lot, which is also sort of oriented around those regulatory requirements. And they're absolutely clear that the annual report structure is way outdated and really problematic. The actual question of environmental services, we didn't get into that.
Yeah. And again, not to belabor the point, but what's driving my question is the interest in trying to understand the degree to which our responses, our being the local health department's responses, to the economic crisis are changing along the lines of actually changing what they're required to do, rather than simply trying to get rid of all of what others consider as fluff.
Yeah, that's a really important, interesting and important point, Paul. Also reminds me of some similar findings from the Washington PBRN study that also, I think, found the same connection to mandates and not necessarily a evidence-driven kind of decision-making.
And I think that that's part of what Tracy's commenting on in her question. She asked whether any of the directors addressed health disparities type services and whether those services were then resistant to changing economic and revenue conditions. And we didn't have anyone address those services that I remember. She also asked
it's Elaine again. I just wanted to chime into that. I mean, if you just look at the staffing of local health departments based on this study, and that's very telling, in terms of how well are the departments aligned with the evidence base. I mean, look at the paucity of nursing, health education staff. I mean, the staff are not very diverse. Environmental. And, can environmental staff perform all of the current functions that are needed? I think we know the answer to that.
So, Debbie, I think you can see some questions posted that I haven't seen yet. So, if there's some other questions that you want to take that you've received via chat.
No, I just got Tracy's.
Oh, okay. Okay, here I've got one from Justine Hyde of the Massachusetts Network. So, Justine, go right ahead.
Can you hear me?
Uh-huh.
Oh, okay. I was just wondering if you could explain why the rural jurisdictions did not receive state funding while the urban ones did. I might have missed your explanation of that, but I found that interesting.
The difference is actually full-time and part-time. The states, Elaine and Jennifer may be able to make sure I get the dates right, but I believe that in 2010 the state said we are no longer providing any state per capita funds for part-time health departments. They want the part-time health departments to shift to districts, to merge into districts, and they're putting money, basically they're providing a per capita allotment for districts and for full-time health departments, but not for part-time health departments. So it's really interesting for us to see that the level of service, the level of funding between districts is very similar to the part-time health departments. That it's not clear that they're able to provide anything like what the full-time health departments are providing. But then again, we couldn't get at any quality indicators of the services provided.
Yeah, that's really interesting.
This is Jennifer. Just to add on to Debbie's comment, in addition to cutting the funding to the part-timers, they also cut any funding to jurisdictions serving 50,000 or less. And one of the other research studies that we're really pursuing with David Gregorio's support is the extent to which that disincentive actually did drive additional regionalization, if at all.
That's really interesting. Thank you.
Great questions. We've also got a question from Chris Malin in the great state of New York. Chris, you want to go ahead?
Yeah, thanks, Glenn. I may have missed this, Debbie, in your presentation, but I'm curious, rather than cutting services or parts or whole programs, did you see any organizational changes that might have emphasized economies of scope, such as integrating programs into one larger unit? And if so, in what kind of areas did you see that?
The districts have more flexibility for that kind of change, and they're the ones that were the more creative in terms of manipulating staffing and having people take furlough days and cutting hours. I can't remember any examples of those kinds of intentional program consolidation, in part because even the full-time health departments are not that large. They cover one municipality, and so the size of our jurisdictions is really quite small. Jennifer, do you know what the largest population in a particular health jurisdiction in Connecticut would be?
Yeah, it's the North Central Health District, which serves about 160,000.
About equal to our largest city, close to, that's it. Yeah, that's even more.
Bridgeport's our largest city. I think that's about 128,000.
So I really don't, I don't remember any.
And so what I'm hearing you say is that organizationally it's not so likely that these smaller agencies are going to take a economies of scope approach to solving their problems.
I'm not sure that they're big enough.
Yeah.
If by economy, this is Jennifer, if you mean by economy of scope also the potential for structural change, you know, there were more districts formed during this period, and in the qualitative analysis there was some reference by a few departments to working more collaboratively with neighboring jurisdictions.
Yeah, I guess where I was going with that question was within a district, if organizationally you have a number of different units within that district that are focused on, say, a chronic disease program or two different programs, by combining those programs under one, where the functions are similar, were they able to be more efficient? And that's an organizational strategy to cope with declining revenue.
One other thing that we're hearing about, but I'm not sure that it came out in the qualitative interviews, is, and this isn't, you know, we have no evidence that it's good, bad, or indifferent, but some municipal health departments are being merged with recreation departments, senior services, things like that.
Okay, thank you very much.
Very good. We maybe have time for one other question, if there's a burning question from anyone on the phone perhaps that doesn't have access to the chat feature. Well, if not, again, thank you so much to Debbie and to Jennifer and Elaine and the other great colleagues in the Connecticut PBRN. This is another very interesting study that I like many. You know, more questions get raised than answers sometimes, and that's a good thing, and can lead you down the pathway toward more research and more meaningful findings. So, thank you so much, Debbie, and great work to you and your colleagues. With that, we do have about a half an hour left on our call for some more mundane items on the administrative side of our agenda for the monthly meeting this week. Again, we are working on some follow-up now coming out of our the PBRN grantee meeting that we had with you last month here in Lexington. Again, it was a great time, wonderful. Again, always wonderful to be able to connect and network face-to-face We had some very good discussions, both in the plenary sessions and I think especially in some of the breakout sessions during the day and a half together. So we are putting some final touches on notes from those meetings and discussions, and we'll be circulating that later this month to folks so that we can capitalize and continue to act on some of the good ideas that came out of our time together. Another thing that we are working on, Rachel and I are working on now, is formatting for those of you in our round 2 networks that participated in the recent social network analysis survey that we presented some of those results to you at the Keeneland conference and at the grantee meeting. We're going to be sending out your network analysis data to you so that you all can use that data and can feel free to do additional analyses and with those data to learn about the patterns of interaction that are occurring within your network and thinking about ways of capitalizing on those relationships. So be looking for that from us in the next couple of weeks. We're putting the wrap on getting those data to you, and also a more full report of the results for your network. Hopefully, you'll find that to be helpful. We are also moving ahead with our improved study, the multi-network study. We had our kickoff meeting for that study in conjunction with the grantee meeting last month. And we have just recently sent out to our participating improved networks 2 items. One is the draft set of selection criteria for selecting measures for the improved study. And we'd ask all of you to take a look at that and give us your feedback. Those will be the criteria that we'll be using collectively to select measures in the 3 domains that we're going to move forward with and collect consistently across our participating PBRNs and analyze collectively. So those selection criteria are obviously an important step in the study design and execution. So we look to your feedback on that. And I think we're asking for feedback anytime over the next month between now and June 15th, when we need to kind of move to the next stage of our measurement development activities. The second thing that we sent out to you all recently on the improved study is our call for measures. So we are now open for business, and we're looking for our participating networks to submit candidate measures that you would suggest for consideration as a measure to include in our core set of measures that will be collected and analyzed across networks as part of the improved study. And so that call should be in your email box. There's instructions on how you can submit those measures to us in the improved study. What we're asking for those of you, again, over the next month, our improved networks to get together as a network, brainstorm, think about the kind of measures that you're already collecting in these domains, think about the kind of measures that you've encountered in other studies or in other work or in other practice-based activities, and put those on the measurement submission form and submit those to the improved study so that we can get those into our inventory of candidate measures. And again, what we'll be doing from there, and again, that's also something we want to hear from you sometime over the next month. We want to receive from each of our networks your list of candidate measures, because we will then be putting those into an inventory and then asking all of our improved networks to go through a process, a Delphi process of rating the measures based on our criteria. We'll use an iterative process to then get us down to a core set of measures to move forward with. Again, if you have any questions on that, don't hesitate to shoot us an email or give us a call here at the Coordinating Center. But we're excited about moving forward with the improved study as well. Just a quick reminder that we're at the Coordinating Center always interested in getting information about your PBRN research results and your products, and especially now as we've had a number of research projects recently conclude or are in the final stages of wrapping up, and to do the best job that we can in helping you disseminate and also helping to synthesize results across related PBRN research projects. We want to make sure that we receive your results and your products as soon as we can. So as you're finishing papers, policy briefs, research briefs, presentations, PowerPoint presentations, all of that good stuff, please send it along to us at the Coordinating Center. Shoot it in an email, and we'll get to work in helping you disseminate, and also helping us to synthesize results across our related public health PBRN studies. We're going to be following up very shortly. We're going to be reinstituting the process we had started last year of doing kind of quarterly check-in calls with each of our networks, just to find out, again, on about a quarterly basis, status of your major projects, and to make sure that we're up to date with all the products that have come out of your network to date. So we're going to be working over the next couple of months and getting caught up with another series of quarterly check-in calls with the key managers of each of the networks, just to make sure that we're caught up with all your research products and results that have come out to date. So just a heads up on that. Some upcoming meetings that you can see here. This is going to be a busy summer for PBRN research dissemination. Coming right on the heels of the Keeneland Conference, we had a great group of studies presented at Keeneland Conference. Again, we're going to be working, those sessions that you presented at Keeneland are going to be up on the Keeneland website. We're also going to cross-post them on the Public Health PBRN website for those of you who may have been presenting at the same time or had a conflict and not been able to see some of the great PBRN research presented at the main Keeneland Conference. We'll have those up on the website for you shortly. But coming right on the heels of that, there are a number of meetings happening this summer where we have PBRN research being presented, and several of these you can see here. There's the American Society for Health Economists meeting that is coming up in Minnesota in a couple of weeks. I'm going to be going up. We actually have 2 panel sessions on public health economics and financing research that are being presented there at the ASH Econ meeting. I'll be going up and presenting some work from our work, and as part of one of those panels, and I'll be moderating another panel that includes a couple of our colleagues from the North Carolina PBRN that are presenting research from their Research Implementation Award. So that's a great opportunity. Those of you who might be at in the Minnesota PBRN or maybe even the Wisconsin PBRN and want to come over for that meeting, it's going to be based at the University of Minnesota, June 10 to 13. For those of you who won't make it, I'll make sure that we get those sessions archived and we get those presentations available and posted on the website. Some great work. This will be the first time that we'll actually have public health PBRN research sessions, 2 entire sessions on public health systems and service research at the Health Econ meeting, so we're excited about that. Right on the heels of that, the National Network of Public Health Institutes will be hosting the Quality Improvement in Public Health Open Forum meeting, the next Open Forum meeting that'll be held June 19th and 20th out in Portland, Oregon. This is an open meeting. For those of you who might be interested in attending this meeting, that really focuses on the latest and greatest in quality improvement in public health settings. This meeting actually is open. They're taking open registrations. The deadline is coming up, however, next week, May 21st. So for any of you who might want to attend this meeting, it is possible to do that. The Institute has invited us to present again another session on public health PBRN research that is being conducted through our PBRNs, looking at quality improvement strategies and their effectiveness. So we will have a public health PBRN panel out there at that meeting that I'll be a part of. I know that the Wisconsin PBRN will be presenting some of their work as part of that session. I think Susan Zahner and her colleagues. Who else? The Minnesota PBRN is also going to be a part of that that PBRN panel as well. Kim Gearin in the State Health Department and her colleagues will be presenting some of their work as well. So we'll have a nice PBRN representation at that meeting. Then just a couple of days later, we're down in Orlando for the Academy Health annual research meeting, June 24 to 26. Another great meeting. And let me tell you, for this year's Academy Health meeting, public health research is going to receive more exposure than any other time in the history of the Academy Health annual research meeting. There will be tracks on public health research in every single time slot of the main annual research meeting this year, largely because of the tremendous response that Academy Health received in terms of submitted research abstracts and panel abstracts at the main meeting. We had the second highest volume of abstract submissions into the public health theme of any of the theme areas at Academy Health, which Academy Health is a broad meeting that includes all of health services research. And so we are now, our work in PHSSR is a major component of Academy Health. We've got the second largest volume of research submissions, and for that reason we're going to have a total of 6 sessions at the main Academy Health meeting, including several sessions that feature public health PBRN research. We have an entire panel devoted to, I think, 4 studies from our PBRNs looking at various aspects of cross-jurisdictional sharing and multi-jurisdictional service delivery in public health that features, again, some of the work in Massachusetts led by Justine Hyde and colleagues, some of the great work in the Georgia affiliate led by Bill Livingood and colleagues, and some work that's underway in Colorado with led by Lisa and Sarah and others. So that's a great session. I know in another session, the Florida PBRN research will be featured, as well as some research from the North Carolina network. So, it's going to be a great meeting for those of you who can make it. And there's also then the affiliate meeting at Academy Health, the Public Health Systems and Services Research Interest Group meeting that will be coming right on the heels of that Academy Health meeting as well, that will also feature some great work in PHSSR. So registration is open until June 15th. Should be a great meeting. It's down in Orlando, so it's the home territory for our Florida network, and we hope to see many of you down there. APHA's mid-year meeting comes right on the heels of that. They've asked us, APHA asked us to be part of a panel looking at research on the economic, estimating the value of public health services and looking at ROI in public health. So I'll be going out there to be part of that panel to present some of our work in that arena. That's in Charlotte, North Carolina this year. And then right after that, I got APHA on there, but I should have on there just a few weeks after that. Oh, it is on there. MACHO's annual meeting, July 11th through 13th. And that's another place where there will be some great PHSSR work presented, and including a panel of research from our public health PBRNs led by Justine Hyde. She put together a panel of research projects, again, from several of our PBRNs looking at, again, issues of cross-jurisdictional sharing in public health service delivery. So that's going to be a great meeting as well out in Los Angeles, California this year. So those are some of the upcoming meetings. Again, I would just ask, as you're preparing for these and get your slides ready or do some research briefs for these meetings, please send us a copy of those at the Coordination Center so we can archive it, put it on our website, so we can use it to produce syntheses and help you get this great work out that you're doing. So, on the topic of dissemination, as we talked about last month at our grantee meeting here in Lexington, we have developed a couple of new dissemination vehicles that we're very excited about. First, in terms of publications, I'll go out of order a little bit. We're putting the final touches on a special issue of the Journal of Public Health Management and Practice. It will be devoted to advances in public health services and systems research and advances in PBRN research. fully a third of the papers that were accepted for this journal, about 22 papers that will be part of this journal issue, fully a third of those are from our public health PBRN. So you guys have done a great job in navigating the peer review process with your research papers, and the PBRNs are going to be strongly featured in this new special issue. I think everybody has gotten their revisions into the journal on time as of last week. Our last few papers came in, so thank you again for doing that. You'll be getting page proofs, copy edits quite soon. One thing to keep in mind at the page proof stage, make sure that pay attention to your acknowledgement section. Make sure that you're first of all listing your funding sources for these publications. We want to make sure that we acknowledge the very important funding support from the Rob Wood Johnson Foundation through the Public Health PBRN program. Also, make sure that your Public Health PBRN is named, somewhere in that paper in the acknowledgement section or in the body of the text. Make sure that you're branding your research projects with your Public Health PBRN identity, because that's an important opportunity for you as you're getting these publications out in particular. And so you'll have a chance to make last-minute corrections or additions, and taking a careful look at your acknowledgement section, making sure that you've acknowledged all the important contributors to your research who may not be authors, your practice partners, and again, making sure that your Public Health PBRN brand is on that publication. Just some things to consider. And again, thank you all for helping us put together that special issue on very short order. We put the call for papers out just in early January, as I recall, so this has been a very rapid cycle effort to pull this special issue together. And it'll be released as the November issue of the journal. It will be out electronically in early October. We'll be doing the journal will be doing some major release activities in conjunction with the APHA annual meeting, which is there in late October, early November as well, so a great dissemination opportunity. We also still have some work underway in putting together papers for a PBRN theme issue in the American Journal of Preventive Medicine. We've got 4 papers from our PBRN projects, mostly related to the Research Implementation Awards that were put together for this theme issue. And I believe now we've gotten feedback, the initial editorial review feedback to everybody on those papers. We're still in scope for getting the theme issue out later this year, but I know the 4 networks that are part of that issue have gotten their comments now and have some revisions to consider and those kind of things. We're hoping to, if we can get those papers resubmitted in the next month or so, we can stay on target with perhaps getting this theme issue out later in 2012, which would be great. And again, we're always glad to help you as you're working through revisions. If there's anything we can do to help, we love to do that. And we also extended to those of you, those 4 networks part of the theme issue, the opportunity to publish an abbreviated version of your paper in Frontiers, the new online open access journal. Now that we have this relationship between Frontiers and AJPM, we can do that, and that's a vehicle for getting some early findings from those papers out even faster this year. So we'll hope you'll consider that, and again, we're glad to help you. Anyway. In terms of, speaking of Frontiers, again, we launched Frontiers officially as a new open access rapid cycle journal last month at the Keeneland Conference. I got our first issue out. Our second issue is nearing completion. Will be out later this month, and we just want to make sure that everybody's aware this is a vehicle that is for you especially in the public health PBRNs. As a rapid cycle vehicle for getting your findings out quickly to a broad audience in an open access vehicle that doesn't have a pay barrier for our You don't need a subscription. You don't need access to an academic library to access Frontiers. And these are peer-reviewed and fully indexed papers. So for those of you who've gotten, many of you networks have findings out as you're thinking about dissemination channels. We encourage you to think about getting that first early bit of findings out through Frontiers. We can get a paper from submission to print in 10 weeks through Frontiers, so it's quite rapid. You'll get very good feedback in terms of the peer review process. You'll also get the articles that are published in Frontiers come with an independently developed editorial comment. We ask one of our colleagues in the field to write a 500-word comment based on your article that also highlights implications for practice and policy. So please be thinking about submissions to Frontiers. The great research we just heard from Connecticut would make an excellent Frontiers article as a way to get some of these findings out quickly. I know you're doing dissemination in Connecticut, but this will help to get findings out to the broad national audience. So please keep Frontiers in mind, and also make sure to go on the Frontiers website. You can sign up to get email alerts, so you're alerted every time there are new findings, new papers posted. Again, you'll want to stay tuned for the May issue that will be out here shortly for another great batch of manuscripts and papers. We're also getting the REACT podcast up and running with our host, Paul Halverson, from Secretary of Health from Arkansas. He's done some recordings already, and we're getting those into production now. So we'll have podcasts that are featuring PBRN research as another dissemination channel here very shortly. That we'll be putting out through the website. We'll be able to link podcasts with Frontiers articles where there's an overlap. We'll be able to disseminate these podcasts as well through a number of different electronic channels with our partnership with ASTO and with NACHO, as well as other vehicles. So our YouTube channel and other vehicles. So again, we want you to keep in mind the REACT podcast as well. As you've got findings that are ready to disseminate, let us know. We'll put you in touch. We'll set up a time when Paul Halverson can connect with your research team and do a quick 5-minute interview focusing in on the highlights of your research and what it really means for practice. If you know Paul Halverson, you know that he's going to probe specifically on the practice and policy implications and things that our public health system can most readily take and use from your research. Okay, these are just a few other meeting agenda items. Just reminders in terms of reporting. Some of you have again research projects that are winding up, that are coming up on your completion dates. And we'll have, reports, narrative reports and financial reports due, bibliographies due. All of the guidelines for how to do these, how to submit these reports are available on the RWJ website. If you have any questions or on what you need to submit, when you need to submit these, feel free to let us know. Please come to us at the coordinating center as your kind of first line of information. We like to try to shoulder these kind of questions as we can to reduce the burden on the RWJ staff in terms of questions about how to submit reports. If you need to submit a request for an extension of a report being due, or even you need to submit a request for modifying your budget or your timeline for your project. We've got all that information and can send these guidelines to you. It's all up on the website of the foundation, but we can also steer you to these and also answer any questions that you might have about the administrative aspects of your public health PBRN grants. Let me see if there's other items here quickly. We have our in addition to our monthly virtual meetings, which we're doing today, we have our periodic PBRN webinars that we do every quarter. and we are scheduled to have another one of these webinars upcoming in July. What we're proposing to do, because our Colorado PBRN actually got missed from the normal monthly schedule of presenting research in progress. They were originally slotted to present at our monthly meeting in April, but since we had our in-person meeting here in Lexington, we did not have an April monthly virtual meeting. So what we've offered to do, and I believe the Colorado group, will is going to do our is going to host our virtual our quarterly webinar. Although I'm stuttering here because I'm getting a message from one of our staff that actually the Colorado Network may actually present at our July monthly virtual meeting. Okay, I see that. Yeah. So Colorado's on deck for July, presenting at our monthly virtual meeting. So I guess our webinar, we will have a quarterly webinar. Stay tuned on the topic for that at this stage. So for our June monthly meeting, Florida is on deck for presenting their research in progress. In our July monthly meeting, in place of Kentucky, we'll actually have Colorado present some of their work in progress. And so that'll be our plan. And stay tuned about for the topic of our July quarterly webinar. We'll be announcing that very shortly. Well, I think that covers our agenda. I do see. We'd be glad to take any. We've got a few minutes here for any remaining questions that there might be. I see that we have gotten a question over the chat from one of our colleagues in Wisconsin asking about. We talked about at our grantee meeting the opportunities for research collaboration with other entities, and in particular, one of the other kind of kindred spirits in terms of translational research entities is the NIH-funded Clinical and Translational Science Award Centers that are up and running at about 60 academic health sciences centers around the country, including many of the universities that are affiliated with public health PBRNs. And so we have been, we talked a little bit at the grantee meeting last month about teeing up opportunities for collaborative research between public health PBRNs and CTSAs, and even the potential for, for jointly funded research projects through the CTSAs. We are, through our National Coordinating Center for PHSSR, we are working directly with the CTSA consortium on exactly those opportunities. And while we don't have anything yet to announce in terms of a tangible project or collaborative opportunity, we do expect to have something to announce in this space later this year. And so I can report to you that the leadership of the CTSA consortium, particularly the leadership of the Community Engagement Key Function Committee and the Comparative Effectiveness Research Key Function Committee, from those two committees, there's a lot of enthusiasm about looking for opportunities for collaborative research between CTSA centers and public health PBRN. So we're working, we're continuing to work on those opportunities with the consortium and with the leadership of the relevant key function committees, and hope to have something to announce shortly. So if you have other questions, feel free to type them into the chat here in our last couple of minutes. I see we got a question from Dr. Shah in the Georgia Public Health PBRNs. His question relates to publications by the PBRN members that are not directly funded by the PBRN funds. What's the recommendation for acknowledging PBRNs in that case? Very good question. It's often the case that that you may have research activities that are ongoing and collaborations that involve members of your PBRN on research projects that may be funded from other sources, not not funded directly from the Public Health PBRN program or from the Robert Wood Johnson Foundation. And my rule of thumb is, as an investigator, is generally to take a big tent approach, and to certainly, in terms of acknowledgments, acknowledge the contributions, whether they're funded contributions or in-kind contributions, from any colleagues and collaborators that might have contributed substantively to the conduct of the research project. So I'd say if you're publishing a research project that's funded through another mechanism, but that has involved some important collaboration with PBRN members, you might want to acknowledge that, and would be certainly appropriate to acknowledge that. Of course, you always want to, with most journal acknowledgement policies now, you need to confirm that that the people you're acknowledging in your acknowledgement section know that you're doing that, and that you have their assent, to acknowledge their participation. But I think if you've got mutual agreement that there's been a productive collaboration involving the PBRN, that it's always good to acknowledge that. And it's certainly fine to acknowledge multiple funding sources. If there are projects that have supported time and effort, from multiple funded projects, it's certainly fine to acknowledge both of those or multiple funding sources in your in your publications. Certainly just thinking about the public health PBRN work, you may have several different funded projects through your network. You might have a quick strike award, and then you have a larger research implementation award, and perhaps both of those projects contributed to an analysis or a research project that you might be publishing. So it's certainly fine to cite both of those grants in your acknowledgement section. Or you may have a CDC funded project that has been supported some work that's relevant to a public health PBRN project. It's certainly a good practice to acknowledge all of your funding sources in those kind of situations where you have multiple projects that are supporting or multiple funding sources that might be supporting a project. But very good question, Goldar.
Thank you.
Anything else before we sign off for today? Well, again, thank you to the Connecticut team. Thank you to Debbie for giving us a very interesting presentation to kick us off from the Research in Progress, and thank you all for being with us today. Again, this session was recorded, will be archived on our website, particularly the Connecticut Research in Progress features, or those of you who might have colleagues who weren't with us and might want to hear the great work that's underway in Connecticut. That'll be on the website shortly. And we will be in touch. Feel free to let us know how we can be of help, and we'll look forward to talking with you soon.